So, one of the things that I talk to my patient about when they have metastatic disease, I don't know if you follow baseball. I follow baseball and football and a lot of sports, but when you're a team manager in baseball, you want to go 9 innings and win the game. Sometimes you go more than 9 innings. You know what's the highest number of innings record? Anybody knows here? 28 innings. And it was a game that was played in Pawtucket, Rhode Island. I don't know if you guys know that. Pawtucket Red Sox is the AAA team for the Boston Red Sox. I'm a Boston fan, so I know that fact. And I trained actually in Pawtucket Memorial, Rhode Island, one of the Brown University programs, so that's how I know this fact. 28 innings. So if a smart manager will try to use his pitchers wisely, because he has a series and he has a number of innings, he doesn't want to tire his pitchers. So he tries to keep the pitcher as long as possible. As long as he's throwing strikes, getting people out, you use the pitcher. Once he starts throwing balls, what do? You change the pitcher. And you hope that the next pitcher will give you more innings, because the less pitcher you use a game, the higher the chance you will win your series. The same thing with metastatic disease. Like I told you, now we understand we want to make it like a chronic disease. So you use a first, like Koi said something to you about the 2 years. I'm hoping it goes 5 years, because we try to keep you in the line of therapy as long as it's throwing strikes. So if your disease is under control, it's not progressing, and you have good quality of life, your toxicity is tolerable, we try to keep you on the same drug as long as you can tolerate it, and as long as it's working. At some time, like he said, he exactly said this, cancer is like a terrorist organization. It mutates, it changes how you fight. You know, when the Americans were in Iraq, they used to suffer from IEDs, improvised explosion devices. The insurgents would make an IED, the convoy comes and used to have wires and stuff, and then they would click and then it bombs. So the Americans figured out how to do it, like look for wires. If you have like scouts, if they see wires, then they know, don't go there. So the numbers went down. Then the terrorists started making them through cell phones, wireless. The Americans figured out, they started jamming cell phone signal. Then these, the terrorists came with different, it's like a cat and mouse game. You find a way to fight the cancer mutates, finds a way to get resistant, you try to find another way to overcome the resistant, and then the cancer mutates and finds a way to come with different resistant. So that's how we fight cancer, and that's, you want to exhaust everything possible through any line of therapy before you switch to the next line. And anytime you get that extra month, or extra 6 months, or extra year, another drug could come up. Ibrance wasn't there 5 years ago. Now we have Ibrance. Now we have 2 other CK4/6 inhibitors. So we get immune therapy is on the horizon. Olaparib wasn't there last year; it just got approved this year. So we have, the people who survived it this year have the chance to get another choice, another option of treatment. So that's what we try to do. Patients ask me, how long do I have? And I give them the same answer. I don't have that connection with God that tells me how long you have. Otherwise, I'd get retired somewhere in a castle and have, money from all the lottery I could win. But the thing is, you want to live your life like you're living forever and be prepared like you're dying tomorrow. That's everybody should live this way, actually. So that's the blueprint for metastatic disease that I use with every cancer, but we're fortunate with breast cancer that most of the time we can treat patients even without giving them chemo, like with the hormonal therapy. The HER2 patients, you can get them into complete remission with the new drugs that we have, and you just have to keep them maintained on those drugs. So we're fortunate these days that we have these options, and I'm hoping in the future we'll have even more options. That umbrella and basket trials, the amazing part is we are treating patients based on the biology of their tumor, not the histology mostly, like what markers, what drivers they have. Pembrolizumab, which is Keytruda, that's the drug that Jimmy Carter got for his melanoma. And this is a drug that made history. Like Koi said, this is the first drug ever that get approved based on a marker, not histology, not based on it's a breast or colon. If you can have cancer of the big toe, if you have that marker, there's no such thing, I think, but I'm just making. So I don't want you to look for your big toes. If you see something there, it doesn't mean it's cancer.
You've seen a melanoma.
Melanoma, that's melanoma. Yeah. But if it has that MSI, microsatellite instability, which has nothing to do with Elon Musk satellites or rockets, you can give them that drug, and that's like, if I'm a Merck, employee, I'll be like, wow, this is like, I'm part of history. I mean, the amazing part about oncology now, people ask me why you do this, it's so depressing. I did this when I realized in the 90s that oncology is going to be the infection disease of the century. 100 years ago, you get a bug, there are no antibiotics, you die. If you have good immune system, you might survive, but you can have 9 kids and 4 of them will die from infections, and you might end up with 5 kids. That's why people used to have a lot of kids. Besides, they didn't invent condoms at those days. So, or birth control pills. But then Alexander Fleming came up with antibiotic, and now we saved millions of people. So it's people still die from infection, but not the same as they did before. And cancer will be the same thing. I don't know if you like Star Trek. Any Star Trek fans here? No? So there's an episode in Star Trek where, it's supposed to be 200 years in the future. So they're looking at some records from Earth, and he reads, a patient was given chemotherapy. So he asked the doctor, what is chemotherapy? And he says, those were the savage days. We used to treat cancer with chemotherapy. And I can tell you, we don't have to wait 200 years. The way things are going, the way that Coy works in his lab and give us information that we use in the community for our patients, we might see this in our lifetimes. We can see that, I'm taking a pill and now my cancer is under control, or immune therapy. I don't need anything to make my hair go away, and the other side effects of throwing up. A surgeon told me once in the 70s they used to have a pocket next to the patient when they give them chemotherapy. They have to get in the hospital. We don't have that now. People get Zofran or other nausea medicines and they go home. So, as much as it can be depressing, but the fact that you can still make a change and see people like yourselves, like that, some of you do have cancer, and again, if I see you in a restaurant street, I wouldn't tell, because you don't have the feature that you used to think about when people have cancer or survive cancer. That gives us, momentum to do more for our patients and to help them keep going. So there are different ways. We try to personalize the care. We try to motivate the patient, and the caregivers we give them the. I do agree with him. The caregivers always rat on the patients, and we like that. We like the caregivers who are rats. Only in this part. Anything else is not good. Don't be a rat in it. But I mean, when you tell about and I always ask the spouses, because sometimes the patient doesn't complain. The other part of caregiving is the nurses that we forget about. Patients are more open to talk to nurses, and as physicians we learn that we have to listen to our nurses and not ignore them, because the patient can tell, I'm fine, I'm okay, and then they go to the nurse, I had a terrible night. And then when you ask him, they say, well, you're busy, I don't want to bother you. And I want to know because I want to help you. So nurses are also an important part of the caregiving. So don't be shy with your doctor. Tell them how exactly you feel, because there could be a solution, there could be a way we can help you feel better. We are not gods. We cannot help with the quantity. That's in God's hand. But we can definitely help with the quality. We can make your life better and help with the quality of how you live. So that's my part, and Dr. Kenneth will have actually more than 2 minutes, 20 minutes.
Thank you very much. It's great to be here this morning. Radiation therapy still plays a very important role in the treatment of metastatic breast cancer. As has already been mentioned, today when we think of metastatic breast cancer, we really think of it more as a chronic disease, really no different than a diabetes, a high blood pressure. And the focus, of course, is total body treatment. We talked about hormonal therapies, chemotherapies, targeted therapies, immunotherapies. These are all ways to treat the whole body and try to control the disease wherever that it is. But sometimes we want to use some localized treatment to try to beat the cancer down where it might be causing a problem. We do have women that are diagnosed with metastatic breast cancer at the outset. So we diagnose them with cancer in the breast, we do some scans, and we find out that the cancer's already spread. And in those cases, radiation therapy can play a role right up front, possibly with surgery, to try to control that cancer as quickly as we can, beat it down, And then, of course, we rely on systemic therapy, systemic meaning, again, total body treatment. But there are situations also where men and women have metastatic breast cancer, where the cancer has recurred in the bone, it's gone to the brain, it's gone to the lungs, it's gone to the liver, and we may have the disease for the most part under control throughout the body, but there may be a spot of cancer that we're not able to control as well, and the cancer is getting a little bit larger, and it's causing pain, or it's causing some other symptoms. And rather than just change drugs and move from one type of systemic therapy to another, if it's working for the most part to control the cancer, and there's one or two areas where maybe that drug isn't working, that's when some localized radiation can play a great role. Breast cancer is very sensitive to radiation, and when you compare it with other types of cancer, we know that you don't need as big a dose of radiation to try to beat down breast cancer cells. So today, just like in the systemic therapy world, where we have more targeted therapies, our radiation therapy has also become much more targeted. The two new machines that we have, for example, at our center, have CAT scanners built onto the machine. So every day before we treat, we get a mini CAT scan. We can see the area that we need to treat very clearly. And I always say, when you can see the target, you can do a much better job of hitting it. Today, because the treatment is so much more targeted, gone are the days of 5, 6, 7, 8 weeks of daily treatment with radiation. Today, in a lot of these situations, we can do the treatment in 1, 2, 3, 4, or 5 sessions. So we can give bigger doses of radiation more safely and really target those areas that we need to treat and really get an excellent response. If you look at what's happened with metastatic breast cancer over the last 25, 30 years, it's really amazing. The common theme today is, rather than throw everything that we have at you, right up front, today we really think long term about what can we do to keep this cancer under control, for as long as we can without burning any bridges. And so today it's not, uncommon for me to work very closely with the medical oncologists, and they, of course, end up following the patients more closely than I do, because they're usually on some type of systemic therapy. But we will jump in whenever we need to give a very short course of radiation. And sometimes it can be a single treatment that can be very effective. So really, again, the focus is, long-term, using what we have available, but using it very judiciously so as not to overwhelm that individual with side effects. Thank you.
Thank you very much, Doctor. I'm going to ask Coy again just to talk about the academic role of treating community and how community and academic work together. Sometimes we send those patients, refer them to academic center for second opinion. Patient asked me about that, and they feel kind of bad. I say, listen, second opinion is great. If they say what I said is right, my head gets bigger. If they say that, they're not going to say I'm an idiot. I'm sure he's going to say, what, I would do it different. Maybe that's what doctor you do. So you learn. We learn a lot from these guys, because this is what they do. We see community practitioner oncologists see all kind of cancers, but these guys, they focus on certain specialty, and we learn a lot from them, and they educate us, and they give us pointers. So
I think that's a great point. I have the luxury that I see breast cancer. If you got cervical cancer, you don't come see me. If you got colon cancer, you don't come see me. Only time you'll see me is if I'm on the inpatient side and I happen to be the doctor who's in charge on that particular day. But in my clinics, I only see breast cancer. That means that I keep up with the breast cancer literature. So those 13 drugs, 9 in the last 3 years, that's just breast cancer. That's not any of the other kinds of cancer. And I can tell you that the rate of new drug development, the rate of new algorithms for treatment for lung cancer is actually, even in the last 2 or 3 years, has been exploding. Lung cancer now is kind of where breast cancer was maybe a decade or 2 ago, in terms of having just this just mind-numbing changes. So I actually applaud the community oncologists because I don't see how they keep up. Because just within the breast realm, we have a lot of advances in every year, okay? So yes, we serve as the tertiary referral center. It's the place for second opinions. It's the place to go for some clinical trials, although many of our community partners have a wide array of clinical trials as well. We tend to focus more on the phase 1 and 2 trials, which is earlier in drug development, because we're trying to find the next drug, as opposed to the phase 3 trials in general is what is in the community, which is comparing that next drug to what is sort of the standard therapy. Okay? So I used to argue breast cancer, I mean, anybody should be able to treat breast cancer, right? My fellows look at me like I'm cross-eyed because breast cancer is complex. It's got a lot of iterations. And keeping up with what's the latest and greatest is not easy. So yes, I have trials that are coming, that are being formed from my research and from the research of others, but we don't know how that's going to act in a human. We know how that acts in a mouse, right? So I have that to offer, and I have the fact that I don't have to necessarily worry about lung cancer and colon cancer's newest drugs, and the best way to treat that. I focus on what's the best way to treat breast cancer, so it's kind of like those of you who have a BMW. You go to the BMW dealership, they have very unique tools, and they have different ways of doing things, and they know the most efficient way of repairing your BMW. If you take your car to the local mechanic, he'll figure it out, and 90% of the time that'll be perfectly fine. 10% of the time it won't. But if he gets the sets of tools, or gets familiar with that situation, has the exposure, that they'll know how to deal with that the next time, right? And BMW dealership's going to charge more. So I completely agree with his assessment. I'm there as a resource. I'm there trying to push drug discovery, and they're on the front lines.